going to be fine on the test. Okay? Because you have to start here, the content, the knowledge, and then we have to apply it. Because you notice the last test, there was a lot of applying. It wasn't just what's normal labs, what's normal vital signs. You had to go further as to what is going on. So if you start here, and for example, COPD, we could go down this list, and I guarantee between all of our brains in here, we could figure out all these things, and we could take the test together and get it right because of what we remember on those concepts, okay? So when you're going through and you're studying, before coming to class, so asthma will be Friday, do this for asthma and see what you come up with. And if you're like, I knew like every cause and every risk factor for asthma, but I knew nothing about the meds, okay? You know where you need to direct your studying because you're not gonna go spend another 10 minutes or 20 minutes studying this outside of class. You're gonna go right to the treatments. I suck at meds, I need to learn meds, right? That might be where I need to go. So always focus on the stuff you don't know. It feels really good to study something that you already know and you're like, I know that, okay? But it takes really the weaknesses on how to get better, okay? So COPD, anyone come up with anything about patho? The pathophysiology. Just kind of pinpointing like, did any of you write anything about patho? Some of you probably put other stuff, but just the pathophys, did anyone write anything on that? Anything? So probably need to study some pathophys on COPD, okay? We're gonna talk about it today. Anyone talk about the causes? Why someone gets COPD? There you go. Probably not a no-brainer, probably was a no-brainer. But smoking pretty common. Did anyone else have any other causes or why someone gets COPD? Asbestos, someone heard. Environmental things, right? So it's not just smoking. Think about environmental. She said asbestos, but it could mean chemicals, long-term, short-term exposures. You know, you guys were probably all pretty young or not born yet, but 2001, what happened in 2001 in our nation? The trade centers, right? 2 airplanes went into there. A lot of the firefighters are showing correlation. Now it's been 20 years. They're showing research that they are getting COPD. A lot of them were like in their 30s, 40s, and they have COPD and never smoked. But short-term exposure to very high amounts of chemical smoke irritants in the lungs have been shown to cause COPD. So it doesn't have to be long-term, you smoked a pack a day for 20 years. It could be short-terms with high amounts, right? So it caused some type of deterioration, okay? Or if you worked in shipyards in the Vietnam War on a ship and you were exposed to asbestos and a bunch of other chemicals or feces or whatever it may be that cause that to go inside your lungs. Could happen, okay? Any other causes?
Welding.
What?
Welding.
Welding, okay, so again, more of like the exposure to some of those things, environmental. But yes, it's just not smoking. So, do you see how this could be a stigma? So if Sid presents a COPD, she's 55 years old, and I go, she must have been a smoker, right? It's not always the case. So don't always think it's smoking. Now, it a lot of times is, but there are other causes besides smoking. Did anybody put genetic? Does anyone put that as a cause? Anybody? Okay. So in about 5% to 10% of cases, there's a genetic predisposition, and they lack this protein. There's a protein in their lungs. Do you remember anything about this in patho? I bet if I said it, you'll know it. You want to say it, Matt? Steroids, is that what you said? A. Think Greek alphabet. Alpha something. Antitrypsin deficiency. Okay? In about 5% of cases, you'll get the patient that presents and at 40 years old, or just younger, not your typical 65-year-old, and they'll say, I never smoked a day in my life. Why am I getting COPD? I never wasn't even exposed to secondhand smoke. Some people have a genetic predisposition called alpha antitrypsin deficiency. Alpha antitrypsin, and the keyword here is deficiency. People that do not have this have an adequate amount of alpha antitrypsin. It's a protein that protects your lungs from getting ill or sick or having COPD. So if you don't have this, you have about a 5% chance of getting COPD without any external causes. So now, what if you have this deficiency and you smoke? You're probably going to get COPD in your lifetime, okay? There's just a very high chance. Okay? You could probably put here with causes, elderly. Not that all elderly get this, but think about this. The longer you're exposed in your lifetime, compared to a 10-year-old versus a 70-year-old, you're going to have a higher risk factor for age because the longer you're exposed to things. So let's say you were a welder, right? So Tracy brought up welding. You're a welder for 20 years. You also smoked, you also maybe were a firefighter, I don't know, all these exposures, right? So someone that works for 1 year compared to 30 years is gonna have a more chance of having it long term, right? The longer you're exposed. So age in itself is a risk factor. Most people, when I say most, 95% of cases are getting diagnosed with COPD after the age of 50, okay? So people that have 40-year-old diagnoses, what do you think the cause probably was there? The alpha antitrypsin, the younger people that get diagnosed, okay? All right, nursing diagnoses, the only reason I put this on here is because if you have an oxygenation issue, there might be some oxygenation nursing diagnoses. So like the impaired gas exchange, the ineffective breathing pattern, those might be things that come up, which they are on these slides, so we'll talk about it. All right, signs and symptoms, it kind of goes back to the pathophysiology, but we'll talk about each one. But you have to have two things with COPD. Remember the two things? Emphysema and chronic bronchitis. So if you didn't have that on your list, that's a pathophys. Essentially, that's what it is. You have to have emphysema, you have to have chronic bronchitis. Talk about what those are later. So the signs and symptoms that we learned today, one goes with the chronic bronchitis and one goes with emphysema, and together they can present with all those symptoms. Okay? Interventions. Interventions are going to be what you do as a nurse to help your patient. So let's think back to clinical. Maybe you have it on your paper. What did you do for your COPD patient? An ascending spirometer, so you're helping with ventilation, keeping the air in there. What'd you say, Max? Ascending spirometer. What was that?
Yeah.
Okay, nebulizer, breathing treatments, probably bronchodilators. What'd you say, Sid?
Sit them up.
Yep, so sit them up, head of the bed up. Very common thing that we do as nurses to get their breathing under control. It goes back to basketball practice. Okay, I'm only saying basketball because that's what I was saying. But you are not going to be able to go run laps if you're short of breath and lay down. That's like the worst thing you can do. When you lay down, your lungs can't expand. So they're like, put your hands on your head. So what do we tell COPD patients? Do the tripod positioning, where you kind of lift your arms up and it expands their lungs, but they can be sitting doing it. They're not going to fall. Okay? O2, oxygen, right? That's going to be a very common thing. You see the little tank, they're little friends. Okay? Hopefully, you can get your patient to stop smoking. That's a huge one. You'll see a lot of people still smoking with oxygen. What's the risk there? It could go boom, right? Oxygen and fire make boom. So make sure that we try to get smoking under control. Right? And there's going to be many, many others. But it comes back down to oxygenation. So the concept of oxygenation, where we learned about in the PowerPoints, your quiz, we're looking at doing adequate lung sounds, making sure we're listening, looking at adequate vital sign, what is normal, and then thinking about some of the meds that go with this component. Okay? Treatment. Is there a cure for COPD? No, it's incurable. Okay? Now, there is one thing that I guess I could probably classify as pretty dang close to a cure. Anyone know what that is? Lung transplant. Okay? It's very unusual to get a bilateral lung transplant. You are a very special person if you get a bilateral lung transplant, okay? But sometimes they can get one new lung, they'll do the worst of the two, and they'll get their transplant, but they still have a bad one. Can we live with one lung? Yes, we can, okay? So they usually say that if you get a lung transplant, it adds about 10 years to your life, okay? How old do you have to be to get a transplant? Or I should say, what age excludes you from getting a lung transplant? Older people, right? So 65 and older tend to not get transplants, okay? Now, ethically, why do we say that?
Not gonna live long.
First of all, they probably have had this problem for a very long time, or they've had environmental things that have been long-term that we still may not be able to fix the other lung, and if we give them a lung, are they going to live? Are they going to actually live for 10 years after their transplant? Could be, could not. So it's individually based, but a general rule of thumb is 65 and older do not get transplants. What if you had a 65-year-old who's doing pretty good, taking their meds, they stop smoking, but they need a transplant? They might do it, okay? I'm not saying never, but the chances are they might not, okay? Another thing is you need to not be smoking to get a transplant, okay? You can't be like, well, yeah, my lung's pretty bad, but I'm still smoking, right? You're not gonna get a transplant if you don't abide by the rules. Okay, and then last is education, probably the biggest part of your test, because this is the way you're going to prevent them from coming back to the hospital or back to the clinic with exacerbations or when they're really sick. So theoretically, if you can do good education and they listen, you're not going to have problems, right? That's the goal. We don't want them to come back with more problems. So education symptoms?
Like activity being a big thing, because obviously it might be like activity tolerance or.
Yep, so it's a good point. So we will talk about that with nursing diagnosis, but activity and tolerance, some of you choose that for your care plans at clinical. In order to be activity and tolerance, it can't be a mental thing where I don't want to exercise. That's not what activity and tolerance is. Activity and tolerance means your vital signs change or you're not able to tolerate the activity if you get up and move, okay? So COPD patients tend to have very small goals. We cannot tell, and this is kind of stemming from your test, so Ryan's gonna hear some stuff, but goals for exercise. What is the goal? 30 minutes a day, 5 days a week, right? That's with the nation. That's like Joe, Jim, Sally, we all tell the same thing. But what if you have a 65-year-old COPD? You're not gonna get that. I'm not saying never, but you can't say go to the gym for 30 minutes and run on the treadmill. That's just not gonna happen, okay? So what do we say based on what Carter was saying? Maybe 5 minutes of exercise 6 times a day. That's realistic. Maybe they get up out of their recliner and they do this while they're doing commercials. It's exercise, right? For them, it's exercise. So doing small goals, maybe saying walking 10 feet, 20 feet, 6 times a day. That might be all they can do. So activity intolerance means they step up and their O2 sats went from 94, now they're down to 82. Do they tolerate the exercise? No, they should not be that low with exercise. When's the best time to do physical therapy with someone with COPD? What would you suspect in like a day's time? I hear it, I think you're saying too. In the morning, so not necessarily right when they get up, but sometime that mid to late morning where they've waking up, they maybe have like got out of bed, moved, and then they kind of have a lot more energy than 5 o'clock at night. Can you imagine running on a treadmill all day, and then at 5 o'clock someone says, let's go do physical therapy? No, they're gonna say, I'm exhausted, I'm fatigued, right? So making sure that you tell them that late morning is about the best time to do exercise. Okay, so let's start with the pathophys. So what is it? 2 components, and you said it, emphysema and bronchitis. Chronic bronchitis. What's the difference between acute and chronic bronchitis? So if you have chronic versus acute, what does that mean to you? So in short, you had it longer, right? So does anyone know, has anyone had bronchitis before? Let's just start there. How long did it take for you to get rid of your bronchitis? Couple weeks maybe? You know, maybe it's a really bad acute bronchitis, a month, you're coughing, hacking, okay? But people with chronic, obviously longer term, they have to have a diagnosis of 3 months out of a year over 2 years' time. So they could get it 3 separate times in 1 year, and it could last a month at a time, that counts. You don't have to have 3 months straight of bronchitis, but let's say you get bronchitis in January, April, and December, and you had it for a month's time. You were coughing, okay? And you got it in 2 consecutive years. So 2021, 2022. I should say that's what happened. You have then classified yourself as not acute anymore. You've gone into a chronic bronchitis, okay? Because can you imagine getting bronchitis 3 times in a year? That's a lot, right? No one probably has that unless they have COPD diagnosis. So you typically tend to get this diagnosis first. A lot of people will get this chronic bronchitis. It's the first thing. They might go years with just having chronic bronchitis. They don't have this diagnosis yet, okay? So theoretically, one or the other could come before the other, but this is primarily what happens first, is bronchitis, okay? So the first thing I mentioned is, what are signs of acute bronchitis? What are things that you had when you had bronchitis? Cough, right? It's probably one of the #1 symptoms. What did I say about coughing, vomiting, pooping, tearing? It's all defense mode, right? You're all trying to get rid of something in your body that should be there. So in bronchitis, bronch is referring to what part of your lung? The bronchioles. Makes sense. There's an inflammation. So if your your bronchial tubes have all this inflammation, okay, your body's gonna say, I'm gonna cough this out. So coughing is a sign of the bronchitis, not emphysema. Okay, the coughing, you're trying to get rid of the mucus, get rid of whatever's in there. Okay, what other things do you have with bronchitis? What are you coughing up? Sputum, phlegm, whatever you want to call it. Can't spell. Phlegm, sputum. What's the difference between sputum and snot? answer that question, right? It is a big problem because when we get a sputum culture, little old ladies will do this. Or they'll cough and they'll be like, spit right into their little cup. That's not sputum. That's not what we're looking for here. Sputum comes from within the lung, okay? So have you ever had like a bad cough and you literally could feel it coming up through your trachea and into your mouth, and you see it? It's usually more thick. It's not gonna be as thin, like the clear secretions that come from just your nose, or like, you know, a little bit of loogie in the back of your throat, those kind of things. It comes from down here. You can feel it come from the back of your lungs here. So sputum is gonna be more so inside of those bronchioles, what's causing the irritation, okay? What is sputum? Let's just think about this for a second. If all this junk is in your lungs, your bronchioles, what is it? Dirt? Okay, so anything you breathe in, yes, it could be that, but what's the underlying, like, why do they keep making more sputum? Like, where is this coming from? What? It comes from the lungs, but what is it made of? Like, if I were to hawk up some sputum, let's look at it under a microscope. What is it?
White blood cells.
It's white blood cells. There you go. So white blood cells, like neutrophils, think back to infection. The first thing that comes to the source of any inflammation is white blood cells, or neutrophils, like purulent drainage. Those are neutrophils. That's what that is. So white blood cells, mast cells, leukotriene, like there's just all these kind of inflammatory markers, cytokines, like they're all of it. But they're all white blood cells, essentially is what they are. So when we sputum-wise cough it up, that's why we want sputum and not spit. Because sputum is going to show us the actual infection process or something that's in there, okay, brewing. So those are typically what you see. Now if I were to listen to lung sound of someone with bronchitis, what does it sound like in their lungs? So think about air trying to get through this narrow space. Wheezing. Could you hear some crackles? You might. Okay, so the crackles are referring to the mucousy part in your lungs. We tend to hear crackles more in the bases of your lungs, so the lower parts. Why is it down there usually first? Gravity. Yep. So if you're standing up, sitting upright, naturally sputum goes down, you're going to hear crackles in the bases. But if you hear wheezing throughout, those are signs that you have bronchoconstriction or you have a very tight chest. So would you agree when you have bronchitis, it was very tight, or tightness in your chest, maybe congestion, you feel like you have that mucus, it's harder to breathe, okay? That's why they have the symptoms of that, okay? So, emphysema. Let's say you also along the lines get an emphysema diagnosis. When you think of that word, what do you think of in the lungs? You should think of this landmark. Alveoli. So part of the oxygenation PowerPoint literally was just showing you, like, what's a bronchiole? What's the alveoli? What happens? Which does seem kind of introductory, right? We learned that physiology. What do the lungs do? In patho, we kind of learned about what goes wrong in those lungs, and now we're putting a diagnosis on top of it, okay? So we have to understand the anatomy of the lungs in order to understand COPD. So alveoli are the terminal areas of the lungs at the very end, okay? So in order for you to take a deep breath in of oxygen, it has to be deep. If you do shallow, what may happen? It doesn't reach the alveoli. Deep breath needs to get into your lungs, and your alveoli then can take that oxygen. Capillaries that surround your alveoli can take it to the rest of the body, and then whatever carbon dioxide or the waste product can come back and come out, okay? So people that have COPD, I don't know if I have a picture on here, but think about your alveoli here. Again, not an artist. If you have air coming in here, normally it should go in and carbon dioxide should come out. But what happens in emphysema? Your alveoli become very stiff, okay? I want you to think about, if something's stiff, it's not gonna have this nice variability where it goes up and down, or in and out, in and out, in and out, okay? So you might hear people that get COPD, they get trapped air, especially trapped CO2. So the oxygen might come in, and the capillaries take it if they can, but then whenever the time comes to get rid of the CO2, it just kind of sits there. And that's why you have chronic what? Carbon dioxide retention. That does happen a lot with COPD, okay? It becomes hyperinflated. Once you become stiff in that alveoli, your alveoli go, well, I'm just gonna try to push harder and get it bigger, right? It's just kind of a compensation thing. So the more it pulls, it gets hyperinflated and nothing's coming down, okay? It's just trying to pull, pull, pull. So you get this hyperinflation of your alveoli, which is where the barrel chest comes in, okay? So the barrel chest in your lungs. So these people, and on our break I'll find you a picture. never seen someone with COPD, they're breathing all day long fast, they're tachypnic. They typically have this hyperinflation of their alveoli, so they have these skinny little waists and these big barreled chests, okay? Why are they skinny? First of all, you're running on a treadmill all day, you're breathing fast, but also, these people are breathing very heavily. Can you imagine eating, and first of all, having an appetite, and eating food while you're breathing really, really fast? It'd be like running on the treadmill and someone's feeding you food. Try it once, it doesn't work, okay? You're literally running, you're like trying to take your bite while you're trying to breathe, right? It's just not appetizing. So a lot of these people don't eat. They might snack a little bit, so they become malnourished. And if you think about working out, you need lots of protein in your diet, right? You need lots of things to keep you going, so you actually have the carbs and proteins and fats to move, okay? So the hyperinflation of the alveoli. This is the pathophys, okay? So the pathophys of COPD is you have two components, chronic bronchitis, the alveoli, the hyperinflation with emphysema. You present with the symptoms because of the pathophys. So if you understand what's wrong, you understand why they have those symptoms. Typically with emphysema, you'll have more of the shortness of breath, the tachypnea and such, but more of the breathing issues, more of the things that you'd see more in assessment. Okay? Progressive, what does progressive mean with the diagnosis? Over time, it gets worse. It does not get better. You can stall where you take medications, you go to your doctor's appointments, you're doing all the right things, but once you've damaged your lungs, you've damaged your lungs. You're not getting them back, okay? Unless you get a transplant. So, if you got a diagnosis at 62, and let's say it's an early diagnosis of COPD, and the person goes, you know what? I'm not gonna die of COPD, I'm not doing this. And they stop smoking, they take their medications, they start an exercise program, they do all these magical things, they theoretically could still live a long life and not have issues. But, let's think of our patients, people that are 65, 62, and they get a diagnosis of COPD, and they still feel good, right? Most people can get into a stage 4 COPD and go, I feel like crap, I wanna stop, right? I wanna stop smoking, I wanna do all this stuff, right? But at that point, is it too late? Yes. So the people that get early diagnoses, they don't get scared yet, because they don't feel like crap, they just feel a little like crap. So what could be the other side of the spectrum where they don't care? They continue to smoke, they forgetful on their meds, maybe they can't afford their meds, like they just maybe don't care quite yet because it's not bad enough. So that's something to consider, is that it's progressive, it's irreversible, there's no cure. So once you get the diagnosis, it will get bad if you don't take the meds and do the interventions, okay? This is alarming. 80% of people that get a diagnosis of COPD, it could have been prevented. Now, this is a respiratory problem, but could we say the same thing about coronary artery disease, heart attacks, strokes, okay? There's a reason why we say lifestyle modifications, right? Or avoiding alcohol and smoking and all those things that cause harm, but we just think about smoking as, well, geez, they did that to themselves. But what if they didn't do it to themselves? What am I talking about? Secondhand smoke, okay? So this happens quite frequently. A person comes in, child, or even like a 20-year-old, where maybe the parents have been smoking around their kids since birth, and 20 years, it's like they smoked. That's a long time, right? If you had a patient that smoked 20 years, you're gonna say, wow, that's a long time. But this kid didn't smoke. They were secondhand exposed. See the ethical dilemma there? Where it wasn't their choice, they just were exposed that way, okay? Now, again, person comes in, they have COPD. Is it our point to judge or to point fingers? No. If you did that, then you're gonna have to go down to your obese patient and do the same thing with cheeseburgers. Or you're gonna have to go down the other one here of your COVID patient because they went to a concert last week and they got COVID at the concert, okay? So this is where, and again, this is kind of an ethical conversation, but we can't pinpoint and point blame on people just because they got an illness, because then you're gonna have to go through all the illnesses and say, well, I'm not gonna take care of you because you shouldn't have smoked, okay? See why that's a problem with COVID, just because they didn't get a vaccine or something, right? So we take care of people all the same, no matter why they come in, what they come in with, and we put our biases aside, right? Because we're gonna perform care for anyone that comes in, no matter what the cause. See how I snuck that in there? Okay, so here is our pathophys, and if you look at this PowerPoint, and you saw chronic bronchitis, excessive bronchial mucus secretion, it's not enough for the test. It isn't, right? So PowerPoints are great, it's a great way to start, but you're not gonna get 100% of your information from the slides. Where are you gonna get it from? Me, okay? I don't think you need to go read the textbook. I just firmly don't believe you need to read the textbook, okay? But you gotta listen in class and take notes or, understand where it's coming from. But if I write something on the board, you're gonna get a little more information on what you can do for studying too. So with chronic bronchitis, when it comes to how you get the diagnosis, I don't think, here it says cough lasts greater than 3 months, okay? Obviously it's in the notes, it's a big deal, but I didn't put 2 years in there, did I? Had to hear that in class, okay? So things that might be special to the exam probably were told in class too. Now, there is a student that's gone today, and I recorded this lecture. I will post it for everyone to listen to, but if it's something you want to listen to again, you can listen to it on my Canvas too. Asthma and COPD. So, with our case study today, when we get back from our break, if we were to present with this information, some of it is very closely related to asthma. The nice thing about having COPD and asthma on the same test is that once you study for one, you really have studied for the other for a lot of things because they're very closely related. And a lot of times you'll get a COPD patient, not always, they said, I've had a history of asthma in my lifetime because they have kind of that precursor, that risk factor of having some of the destruction of their inflammatory processes, they've had irritation within that lung, or they've had the same exposures. So let's say your asthma patient, parents smoked, okay? There could be some irritation there, and it's a cause for both of them. What about meds? Asthma and COPD. They're like the same, almost identical. So another thing that's nice for this test, if you give some to one, you're almost always giving it to the other as well. So they really do 2 different diagnoses for one set of meds. Okay, let's talk about smoking. What is third-hand smoke? I put it in the comments down below. We all know what secondhand is. I just talked about the kid, 20 years exposure, never physically smoked. Third hand is where?
I mean, like if it's on your clothes.
It's on your clothes, it's in the linen, it's in the carpet, it's in the bedding, right? Or whatever is something that you're exposed to where somebody's not physically smoking, but the residue it leaves behind is going to put you at higher risk, okay? This is for the people that stop smoking or they haven't smoked for 6 months, but you go into their house and then you leave and somehow you smell like smoke. You're like, they never smoked. It's on your clothes. It becomes kind of part of the residue inside the house. This is before your time, but in 2008, smoking was considered illegal inside of restaurants and bars. I don't know if you guys remember that, but my parents have a bar in Kennebec, and I remember when that came out to be, first of all, why did that happen? It wasn't to say to smokers, like, don't do that. It's because what was happening? Secondhand smoke. So you would go to a bar, club, whatever, and you'd go home and reek of smoke and were exposed to secondhand smoke for hours on end, right? So it was for the good of all people to make sure they're not getting exposed that way. For people that wanted to go to a restaurant or a bar, not have to worry about smoking. But what happened, so after the fact that smoking has cessation or stopped in 2008, what did the bar establishments look like when it stopped?
Dead.
What's that?
It's dead.
What's dead?
No, like the bars.
Well, I mean, there was a
People
time
wanted to
frame where there was. Like, my
Nobody
parents were worried that they were gonna have to close their bar because
Yeah.
people couldn't drink and smoke. Like, they had to either, once they had a drink, they popped their cigarette. It was kind of a routine thing, right? People got over that real fast when they realized that they want to still drink. Okay, they'll just go out and smoke. Or they'll make little smoke shacks. Like, you've all seen them. Like, it's the way to secretly bring smoking in, but you don't really have smoking. But anyway, what I'm trying to say is, what was kind of left behind of what they saw inside these establishments, once the lights came on, it wasn't dark. The walls are yellow. Like, literally, if you look, or the linens, most people don't have, like, curtains in bars and restaurants, but some do. It was, like, in everything. So you almost had to get rid of, like, probably not carpet in restaurants, but, like, some of the linens and the curtains, and they had to paint their walls, right? Some of them even have, like, ventilation systems to get the smoke out of there because it was taking so long for it to ventilate. So think about people's houses. When they stop smoking, does it really stop there? No, it has to go further, okay? So the short-term exposure I was talking about are people that, I was using the 9/11 for example because that is what they've shown with research, but it can happen for anything. If you're a farmer, for example, you're exposed to chemicals and you're supposed to wear masks around some of these chemicals because it does irritate your lungs, but even simple exposures, once or twice or limited times for like a month, could potentially cause harm to your lungs. So it's not this everyday thing, it could be short-term, high amounts. Okay, and then here's your environmental. Someone even said asbestos, I think it was Sydney, okay? Coal, so let's say the people that work in mines, they could potentially have that. And then any type of fumes, so the welding, okay? Okay, so here are your clinical manifestations. I didn't wanna say everything, because I wanted you to tie it together. But if you think about people that have mild or late, or early versus late, you're gonna have way different symptoms. That's why people, when they get early diagnoses of COPD, they're not gonna be like, let's conquer the world and stop smoking. Like, they usually don't get that kind of scare until their first hospitalization, or their first, time to the clinic where they can't breathe. Okay, it usually happens with later diagnoses that they start to actually listen to the symptoms. Dyspnea on exertion. So what does that mean to you?
Out of breath when they like do an activity.
Yep, so every time they get up, they get this trouble breathing. So typically people that have dyspnea with exertion will be on oxygen, and what they'll do is they'll give them a range of 2 to 4 liters. So you'll see this very commonly in COPD when they are on oxygen. When do they get 2? When do they get 4? 2 with rest, 4 with activity. Okay, so they tend to say when you're sleeping at night, you're sitting in your recliner, you get 2 liters. Let's say you get this dyspnea with exertion, bump it up to 4, and then once you go back down, turn it back down to 2. What's the problem with that? They have access to oxygen. So, what did I say about people that get scared when they can't breathe? They'll do anything to help them not breathe, or not have trouble breathing. So they might bump it up to 6, because they can, and what happens to them? Oh, this feels really nice, I love this oxygen, it makes me feel real good, right? So oxygen is good in small amounts for short periods of time, but if they have it and they're like, oh, or they forgot to turn it back down to 2, they're gonna get 6 liters at rest for maybe 24 hours or 2 weeks, depending on the situation. What does that do to your respiratory drive? It lowers it, and then you're like, oh, oxygen's in my body, I can slow my breathing now, I feel good. But COPD patients should not be at 12 or even 10 for respiration. We want them to be a little higher if we can, so they don't retain CO2. There was a term on your quiz today, paroxysmal, I don't think I have it on the bottom here, but paroxysmal nocturnal dyspnea. Now, anyone in this room probably saw that and goes, oh my God, what is that? But let's dissect the word. Is there any words that you knew what they were? Dyspnea, trouble breathing. Nocturnal, if an animal's nocturnal, they're up at night, so something with nighttime. Paroxysmal, that one might have tripped you up. What is proximal? What's that? No, it's not laying flat, that's orthopnea. Orthopnea is the laying flat and you can't breathe, but paroxysmal means it comes and goes. Okay, paroxysmal means like when you have paroxysmal SVT, that heart rate that goes really fast, that is not something that's constant, it just kind of comes and goes. So paroxysmal, you're gonna have it comes and goes, probably at night is when it comes, it goes when you stand up. Orthopnea is when you can't breathe lying down. Okay, so that comes back to nursing intervention. The best way to breathe is upright. So when you lay down, naturally, it makes sense you can't breathe. So those are things that happen with COPD. And then here, I put different stages for you. So if I say on your test, stage 4 versus stage 1, that gives you an idea as to how bad it is. So stage 1, you're not gonna probably be doing all these hardcore things. They're not gonna be on oxygen. But stage 4, you're looking at end of life care almost, to the point where they might even be on hospice because it's so bad. It's kind of longer in the period. So what's the time frame? So let's say if you get a patient that says, I have a new diagnosis of stage 1 COPD, how long will it be before I'm in stage 4? It depends on the patient, right? Good thing. So can you kind of help your destiny here? Yes, because if you get a stage 1, theoretically, if you take your meds and you do what you're supposed to do, it might be 20 years before you're stage 4. But if you don't, you might go into stage 4 in 2 years. So you have to consider the situation, the patient. There's no magical timeline. It's all based on how you take care of yourself. Okay? So here's kind of just some signs of each one. So if it's in the comments, it probably means something, right? So people that have chronic bronchitis are typically going to have that sputum, that cough. And the only reason I put cyanosis on here is because if you have wheezing to the point of occlusion, they're getting no oxygen in, okay? So you have to be able to get from the bronchioles to the alveoli, but if nothing can get past the bronchioles because of inflammation, you have no airflow. Person can become cyanotic for that reason, okay? Right-sided heart failure. So if we know the blood flow through the heart, let's think about this for a second. Your blood flow through the heart starts on the right side, then it goes to your lungs, and then hopefully your lungs oxygenate your blood, go to your left side and pump to your body. But what if the person doesn't get adequate oxygen to their lungs, or carbon dioxide is kind of trapped in there? It can cause this pressure on the right side of the heart, okay? So it can cause right-sided heart problems if for some reason you're not getting the ventilation or the oxygen in your blood. So people can have right-sided heart failure. We learned from our last test, what does right-sided heart failure cause? It goes back into systemic circulation. So what vein feeds into that right atrium? Yep, your superior vena cava and your inferior vena cava. So people that have right-sided heart failure, ground maybe COPD, you'll get fluid that goes back up here and down here. So that's why you tend to get like hepatomegaly, splenomegaly, and JVD, because it goes up into those vessels, okay? Anyone remember what right-sided heart failure is called? There's a special term for it. Starts with C. Max likes when I say, what's it start with? It's a special name, you might hear it used interchangeably. So right-sided heart failure can be called, this is the first word, cor pulmonale. Okay? Cor pulmonale is a code word, another word for right-sided heart failure. Okay, so let's put all this together. Patient has pretty severe COPD, we'll call it stage 3, so it's up there. And the person is exhibiting JVD, hepatomegaly, splenomegaly. That's your hint to say, okay, right-sided heart failure. Which of the following would you classify this problem as? You're looking for cor pulmonale. Okay? Tying that together with what's the problem, what are the symptoms, what's it called? Cor pulmonale. And then here's your emphysema. I think I talked about most of these. But emphysema tends to have more of the barrel chest because of that hyperinflation of the alveoli. What would you see on an x-ray? So chest x-ray, it shows a distinct look to your lung. Because you'll see barrel chest, but you have the hyperinflation of the alveoli, but you also see some with your diaphragm. Again, not a drummer. Okay, one of these is COPD, one of them is not. One of them is, we'll just say this is my lungs. This one's COPD, okay? So one of the first things that you will look for an x-ray, which nobody in here has to read an x-ray, it's not really in your scope. However, if you think about the pathophys and you start reading the impression on a chest x-ray that comes back, it is not your job to analyze what it says, but you need to look at the report and what it's telling you. They are not gonna say, looks like COPD lungs. They don't say that, okay? So we're looking for two things. One of them is the hyperinflation of your lungs. You will actually see, especially if you look at a previous x-ray, it's not gonna be as expanded, but here it's gonna look way bigger in your lungs. It's hyperinflated, okay? So it's because these alveoli become so enlarged and stiff over time, they don't deflate like normal, okay? They just kind of become hyperinflated and stiff, and they stay there, okay? Another thing is, notice this curve, and this is more flat. So your diaphragm becomes flat. Why? Pushing from the alveoli, you don't have this nice curvature that you normally have, you have more of a flattened diaphragm. So if you see an impression, and when I'm saying impression, at the very end of a chest x-ray report, you get the picture, and you get the actual formal document that says what's going on, the x-ray specialist will say, hyperinflated alveoli with a flattened diaphragm. You're gonna say, looks like COPD, right? So it's a pathophysiological thing that it's explaining, but now that you know what happens in the lungs, you can identify on an x-ray what they're asking. Okay, so you might see that on your test where it says, the x-ray comes back with hyperinflation of the alveoli with a flattened diaphragm. It's me telling you they have COPD.